Right, cancers can be solid tumors or they can be blood cancers. In the case of blood cancers or hematological malignancies, we're talking about diseases affecting the bone marrow. However, in the case of leukemia, although technically it's a blood cancer, they can go on to form solid tumors, particularly in the lymph nodes. But most cancers are solid tumors. We will discuss the staging shortly. All right, let's go now to how do we recognize cancer? The acronym CAUTION is the oldest basic signs and symptoms of cancer. They cover most types of cancer. For instance, if you look at box 13.1, so it stands for C would be change in bowel or bowel or bladder habits. So what type of cancer is this most likely?
Colon.
Okay, colorectal cancer. What about if it's a bladder? Let's say you're having hesitancy all of a sudden, or um, inability to urinate, urinary retention.
Bladder.
So, yeah, bladder cancer. Although with bowel, they can compress structures in the pelvis, so that might lead to some um, urinary changes as well, but it doesn't necessarily have to be colorectal cancer or bladder cancer. Sorry, this can also be any other tumor growing in the pelvis. So let's say in a female, you may have a tumor in the uterus, for instance, and it's in the same pelvic area. So this may, if the tumor is big enough, they may also cause bowel or bladder habits, changes in the bowel or bladder habits. As far as a sore that doesn't heal, it really depends. Where is the sore? The sore's on the, say, in the breast, the sore's on the skin, the sore is in your um, neck, for instance, or in your mouth, wherever the sore is. Unusual bleeding of discharge, same thing. Where is the unusual bleeding coming from? Is it coming from your ear? Is it coming from your nose, from your rectum, from your urethra, for instance? And we go on to thickening of the lump. Well, where is the lump? Obviously, if it's in the breast, then it's possibly breast cancer, or wherever that lump is. You could have lumps around your neck, around your chest, in your around your um, chest area, or in your abdomen. And then as far as indigestion or difficulty swallowing, that could be anything from nasopharyngeal or throat cancer, laryngeal cancer. It could also be bronchial cancer. They're big enough that will impair swallowing. And O, obvious change in the wart or mole, then that's definitely melanoma. And finally, N is nagging cough or hoarseness. Could be bronchial, laryngeal, throat, or even lung cancer. Most cancers cause anemia. The reason for the anemia here is, as we discussed last week, what is the appetite of cancer cells? Do they have the same consumption and needs as normal cells? Because of the fact that they rapidly grow, divide, and even invade tissues, what can you say about their cellular activity, and therefore what is their metabolic need?
I would say they have a high metabolism, metabolic
Okay,
needs.
right. So therefore, how would you characterize their oxygen consumption?
They use up a lot of oxygen.
All right. So they can rob the body of vital nutrients. The patient therefore can be either malnourished or even go anemic as a result. And we already know that is pain associated with cancer?
Yes.
All right. So pain, in fact, when you have a diagnosis of cancer, besides, so let's say I tell, is there any mom in the class? Any mom here? Are you a mom, Jasmine? Vivian, do you have any kids, Vivian?
Yes, Professor.
Okay, so if a doctor tells you right now that you have cancer, what would be the first thing in your mind?
Cancer.
You're told today, like right now, this minute, that Vivian, I hate to tell you this, but you have a cancer.
The first thing not I would think about my
You would think about what?
my daughter.
Okay, so are you thinking about yourself?
No,
No, right? Because what is it about cancer? Is it why did it make you think about your daughter?
because I know they're gonna die. I don't know.
Okay, so it's usually that diagnosis is usually associated with death, correct?
Y- Yes,
Death, and there's pain and suffering that goes with it. But as a mom, of course, the first thing in your mind will be who's going to be left behind, right? Because you're the mom, and who's going to take care of your children. So if you're asking why do we need to know, let's say when we get to staging, the reason is although the doctor explains the diagnosis, because of the grief associated with cancer, it's usually we associate it with death. The patient is in no open mind to listen to the diagnosis and to the plan of care. Although the doctor discusses all these, you think that this will sink in to the patient's mind at all? Will she be listening to the doctor? No, just like with Vivian, for instance, all she thought about was her daughter. So later, as she moves on with her stage of grief, whenever that is the doctor going to wait around for that moment?
No. So probably the
All
nurse
right.
will explain it.
Okay, so by the time they reach acceptance stage, whenever that is, it'll be the nurse that's there. So that's why we still need to know how cancer works, what is the primary and the secondary tumor, and then also with staging. That's the reason why we need to know. Um, Plus, we're not the ones really giving the primary information. We are merely reinforcing what was already said. Here are some common factors for cancer. Just take note that as listed here, look at the under tobacco. Is it only related to lung cancer? No, we have bladder cancer, we have bone, skin cancer, liver cancer. So the toxins found in nicotine in tobacco leads to more than just lung cancer. It's associated with other types of cancer as well.
Professor,
As far as, yes,
why is it
go
not
ahead.
linked to breast cancer? That was something that I knew before. But do you know like any specific reason why tobacco or smoking is not linked to breast cancer?
I have no idea. These are statistics taken from American Cancer Society. They list down cases and then look at the patient's risk factors. Then
Okay.
they make sense. Yeah, these are all just based on data. Meaning this is all filled with different types of cancer and they have identified risk factors. We don't know whether it's really only um, say obesity or high fat diet. We know that breast cancer does run in family, so that's why they listed it here that it's genetic propensity, but we don't know. It could be smoking as well. It's just that they probably don't have enough data yet to really pinpoint that it's caused by smoking. So I won't read the whole table for you. This is table 13.2. How is this asked on the test question? Well, let's say select all that apply. Which of the following have been identified as possible risk factors for, say, um, colon cancer, for instance? Then select all that apply. Okay. I typically would like to discuss oncologic emergencies in the end, but since they mentioned it here, then we'll talk about them. Oncologic emergencies are complications arising from either the cancer itself or cancer treatment. Right here. So oncologic emergencies may be secondary to processes of tumor growth and invasion of body organs, or as a result of treatment. Again, these are emergencies, so therefore what comes into your mind when it's an emergency, Miss Lou? When something is considered an emergency, what comes into your mind? Is she here?
Can I say?
Yeah. So what does emergency mean?
Imminent death.
Okay, these are life-threatening, right?
Yeah.
So being they're life-threatening, are they going to be on the NCLEX?
Probably.
All right.
Most
Well,
likely.
not probably. Most definitely, yeah. Okay, so they're all in table 13.3. There's quite a few of them, but I'm only testing the ones that I highlighted. So for table 13.3, first one is hypercalcemia. So which columns do you study? The signs and symptoms first, and then the interventions. Again, for table 13.3, what do you study? Signs and symptoms, because you need to recognize their presence, and then after that you need to know what do you do. Some of these we've already discussed in prior chapters. For instance, in hypercalcemia, which module do you remember this was from in last semester? When did we talk about hypercalcemia? Which patient experienced hypercalcemia? Hyperparathyroidism, right? And also in CKD, right? Chronic kidney disease. So what is the problem, or how do you identify hypercalcemia? So you have it here in your last, no, third, sorry, third column. common signs and symptoms. So the patient will have somnolence, muscle weakness, polyuria, bradycardia, nausea, constipation. And then what do we do about it? Okay, hydration plus diuretics, right? Biphosphonates are added. What disorder is treated with biphosphonates? This would be MedSurg 1. When did we use biphosphonates like pamidronate, solendronate, or zoledronate, alendronate?
When the calcium,
What was that, Vivian?
when the calcium is low.
Actually, when the calcium is
No, it's high. Low.
yeah, because this is hypercalcemia. You're thinking about osteoporosis, right?
Oh, okay.
Okay, so in osteoporosis, we gave alendronate so that we will deposit the calcium back into the bone to strengthen the bone. Does that make sense? So here, how did the patient develop hypercalcemia? Did they take a lot of calcium that led to the high levels?
No.
No, the cancer here caused the breakdown of calcium from the bone. So this is, as listed here, this is caused by cancers that metastasize to the bone, increasing osteoclastic activity or breaking down calcium from the bone. All right, and next one is spinal cord compression. This can be a primary or a secondary tumor to the spine. What are the signs and symptoms? Patient will have back pain, and there will be potentially sensory motor loss, because this technically is spinal cord injury. So spinal cord compression will manifest, of course, signs and symptoms of spinal cord injury, which may include hemiparesis or paresis or paraplegia. And these are your treatments. Surgery may be necessary if the patient has evidence of paralysis. So if they can relieve pressure on one or more spinal nerves to restore sensory motor function, then that will have to be done. Next is superior vena cava syndrome. Look at the cause. These are usually tumors growing in the chest. So we're talking about a lymphoma, for instance, or leukemias, like I mentioned, which grow tumors on lymph nodes. And if those lymph nodes, the affected lymph nodes, are around the thoracic cavity, because we have lymph nodes around the heart. So when you have a big tumor on either side of the heart, what happens to the superior vena cava?
It's compressed.
Say you have, you have a large tumor growing in the middle of your chest. What will it do to the superior vena cava? It will compress it, right? So when you're squeezing the SVC, and what is the job of the SVC? What is it supposed to do?
Bring blood back to the right atrium.
All right, so all blood, where did all that blood come from?
Your brain and just upper levels.
Okay, so from both upper extremities, your chest, and your head. So if you squeeze or compress the superior vena cava, what happens to all that blood that is supposed to enter the superior vena cava to return to the heart? There will be congestion. So congestion in the upper extremities, congestion in the head. Now imagine what this patient will look like. Picture the patient. Will there be any congestion and edema?
Yes.
Yes, but
Okay.
Pastor, your brain can expand though, so would like it back up in your head as well?
Yeah, that's why I'm asking, what will be the patient's picture here? What will they look like? They have SBC syndrome.
Puffy face, maybe edema of the arms.
All right, so you'll have edema in the face, periorbital edema, you'll have distended neck veins, you'll have edema around the neck on the upper arms, and then you'll see engorged veins, spider angiomas that will form in the upper chest. Um, will there be increased intracranial pressure? Will there, will
Yes.
there be increased intraocular pressure?
Yes.
Okay, so now imagine you have less blood return to the right atrium. What happens to cardiac output, therefore?
It decreases.
Okay, so on top of the patient not looking good, plus what will be, because now you have congestion, all this congestion in your thorax, will it be easy or hard to breathe?
It'll be hard.
All right, so now you have your signs and symptoms here. So you have venous congestion, edema in the upper body, visual disturbances, headache, which is a sign of ICP, so is altered mental status. You have cerebral edema, plus again, periorbital edema will also be present. Jugular veins, brachial veins, chest vessels will all be distended. What do we do about it? So we expect chemo and radiation to decrease the size of the tumor. And if they do form blood clots, because anywhere you have congestion, there's a likelihood, right, of the patient throwing a clot or even rupturing a vessel. It could be one or more vessels that may rupture as a result. Again, the patient will have low cardiac output here, resulting in confusion, cyanosis, hypotension, and tachycardia. Next, SIADH. So we discussed this in fourth semester, correct? Along with diabetes insipidus. So what type of cancer can cause SIADH?
Brain or lung cancer?
All right, because in the case of lung cancer, it will have to be metastatic lung cancer, which metastasized to the brain. Because remember, the list of causes for SIADH, they included brain tumors, traumatic brain injury, as well as brain surgery. Right, so all of these, stroke, sorry, I forgot stroke. So any condition, either a tumor or anything that will increase intracranial pressure, meaning you have something growing in the head which causes any damage to your hypothalamus, that can lead to SIADH. Signs and symptoms, you're experts already. We did this last semester. So the patient is in fluid overload. There's delusional hyponatremia. There will be, what happens to the urine output here? Okay, so you have oliguria. You have less urine output. And management, again, we did management already of SIADH last semester, which include what? Diuretics. What else? But is diuretics your first intervention here? Because remember,
When we
diuretics will cause a decrease in sodium. So what
Wouldn't it
will
be
be
fluid
your...
restriction?
Okay, number one is fluid restriction. What do we do about the sodium? The patient has delusional hyponatremia. Okay, so we replace sodium? Yes, right here. So fluid restriction, and then if needed, then we'll have to give hypertonic saline. But remember, when we say hypertonic saline, that's 3% sodium chloride. So that what will happen to your fluid volume if you give hypertonic saline? By osmosis, what is the effect of any hypertonic solution to fluid volume, particularly vascular volume?
The hypertonic solution would bring fluid into the vascular system.
Okay, so what happens to your overall blood volume?
It increases.
Okay, so just use this cautiously, okay? So always look at blood pressure before you administer hypertonic saline. Next is tumor lysis syndrome. Of all the oncologic emergencies, this one isn't all bad news. This actually starts as a good news because that means if there is tumor lysis, is our treatment effective or not? Yeah, we're successful in destroying the cancer. However, this may kill the patient at the same time because remember, these tumor cells are just like normal cells as far as their cellular contents. So what does every cell contain? And what happens if you destroy any cell? Okay, so when you open a cell, they spill out their guts, which contain potassium. What else? You destroy the cell, so will there be uric acid? Okay, you destroyed. Let's say it's a muscle cell. Okay, will there be myoglobin as well? All right, so your problem here are usually metabolic. So you destroyed cells, so you have hyperuricemia here. Will the patient have gout symptoms? Can this also destroy the kidney? Yeah. So either what about hyperkalemia? Is that an emergency as well? All right. So the patient will have hyperkalemia and hypocalcemia at the same time, acidosis because of the uric acid buildup, which especially the hyperkalemia here, can cause dysrhythmias. So what do we do about it? So there's quite a few problems here. So we're dealing with acute kidney injury, we're dealing with hyperkalemia and hyperuricemia. So look at your interventions, it's quite long. First, with the hyperkalemia, what are your interventions again for hyperkalemia? It's not really listed here anymore, but it's a given that we did manage hyperkalemia last semester. And also in adrenal crisis, right? Yeah, adrenal insufficiency. Was there hyperkalemia? Okay, so what are your interventions again for hyperkalemia?
You can give a non-potassium.
All right, what else?
IV fluid.
Insulin with
IV
dextrose.
glucose.
Yeah.
Yeah, insulin with
Calcium gluconate. Did we give also the Diuretics, furosemide, right? Okay.
Yeah,
Did we give sodium polystyrene sulfonate, KXLate?
Yeah, I just
Yeah.
All right. So that's for hyperkalemia. And then for hyperuricemia, we treat them just like any patient with gout. So we give, how did we do gout last semester? Allopurinol, colchicine also. And of course, a low purine diet. And how do we monitor and treat acute kidney injury?
you monitor like the oliguric.
Okay, so you see elevation of your BUN creatinine, and then what do you do about it? Do we give fluids?
Yes.
Well, depends. What phase of acute kidney injury is the patient in? Are they in the oliguric or the diuretic phase? So please don't forget what we learned last semester. So here are your interventions. Any questions? So how many did I highlight here? 1, 2, 3, 4, 5, right? Hypercalcemia, 5. So just those 5. Any questions? All right, let's proceed. Prevention is divided into 2 parts. We have primary and secondary prevention. There's actually a third, tertiary prevention. For primary prevention, these are your activities. So we encourage the patient to modify risk factors, specifically, let's say smoking, for instance, poor diet, losing weight. So those are your primary preventions. Immunization. What immunizations again can prevent cancer? We talked about some cancers that can be prevented with immunizations last week.
The HPV vaccine.
HPV, very good. What else?
Hepatitis B. Hepatitis.
Hepatitis B, right? Those were the only 2 we talked about, right? I think so. Yeah. And we also have something called chemo prevention. It's increasing in use nowadays because again our approach for cancer is usually preventive. It's much harder to treat cancer than to prevent it. So again, if it's primary prevention, it's risk factor modification. It's different now when we say secondary because in secondary, it now involves screening. Now, why did we screen a patient? So let's say I'm a 45-year-old female and I have cancer in my family, breast cancer in my family. So you submit me for mammograms, for instance. Why does that fall under secondary? When in fact it's still prevention. Okay, before you answer that question, let's finish primary prevention. So there are examples here on primary prevention. So they are, like I said, stop smoking, or if you don't smoke, then never start. We also have eating healthier, eating less red meat, avoid known carcinogens, like chemicals, for instance, industrial chemicals, exercising, losing weight. So these are all going to fall under primary. Why are these primary? Does the patient have the risk factor yet?
No, but these are the studies
No,
for the
we're trying to avoid them, right? So we're
yeah.
trying to avoid the known risk factors. That's why they fall under primary prevention. As far as secondary prevention, and you have examples here, box 13.2, these are all your primary prevention. And here's example of your chemo prevention. Now look at the activities under secondary prevention. Do you have the risk factor? Now you do. Yes, you have the risk factor. So that's why we screened you. Do we screen everybody for cancer? No, only those that have risk factors. Now, what did we learn last week? What was one of the non-modifiable risk factors for cancer? Besides that, because when you say genetics, then that means we'll have to take a history or even do genetic testing, which again is still part of secondary prevention, but it concerns all of us. What would be everyone's risk factor for cancer? Age. So when we hit a certain age, we increase our risk for certain types of cancers. To answer this, we will have to go to cancer.org. So go to the American Cancer Society website, type in cancer.org. Okay, you see my website, right, on the screen? American Cancer Society?
Yes.
Okay, so you need to scroll down to right here, stay healthy. This tab, reduce your cancer, under the stay healthy tab, click that once. And then scroll down here under cancer screening guidelines. This gentleman right here, click that. And then scroll down on the first tab right here, American Cancer Society Guidelines for Early Detection of Cancer. Click that, and I'll only be testing the first three: breast cancer, colorectal cancer, and cervical cancer. The first two were listed as the top 5. If you look at, if you remember last week on the earlier pages of chapter 13, there was a table showing you the incidence, right? The most common cancer cases. I believe it was breast and then prostate for men, and then followed by lung and bronchial cancer, right? Although cervical cancer wasn't listed there, it is listed here in the American Cancer Society. I don't know what number it belonged, but cervical cancer is still probably in the top 10. So let's start over. To get here, you type cancer.org. Scroll down to the Stay Healthy tab. Right here, Stay Healthy, reduce your cancer risk. Scroll down again to Early Cancer Screening Guidelines. And finally, the first tab that follows, right here, ACS Guidelines for Early Detection of Cancer. We will only test the first 3: breast, colorectal, and cervical cancer. For breast cancer, what age should we start? But please take note of, okay, well, no. Look at the age and
Well,
look at the verb that they use.
should have.
For women age 40 to 44, can they have mammograms?
Yes.
Okay, they have the choice, should have the choice, meaning if they want to, yes, they can have one for free. Insurance will cover it because this is covered under wellness, meaning preventative care. This is covered in all insurance. This is a basic coverage. So even if you have the most minimum insurance coverage, it will cover mammograms because you have a choice. You are between 40 and 44. But if you don't want to, fine. Okay? You don't want, because the the mammogram that they use here is the basic, which the one wherein you'll put your breast up on a plate and it'll be between two flat plates, and then they'll squish your breast under there in order to examine the tissue. So they're like making a panini out of your breast. It's quite painful. For if you have better insurance, they may cover the 3D or even 4D mammograms, which do not involve panini making. When we go to older women now, 45 to 54, look at the verb that they use. It's now should get, meaning they highly recommend you should get one once you're 45 to 54 years of age. And then look at the frequency when you hit 55. Why does it decrease? So 40 to 44, it's a choice. 45 to 54, you should get one every year. And then once you hit 55, you can do it every 2 years. Why is that? All right, so what's happening when you're hit 55? What happens to women when they hit 55? Something for you to look forward to?
Is it menopause?
All right, so menopause occurs. So therefore, your hormones aren't as stable as they were between 45 to 54. So it's really the premenopausal stage that, since your hormones are so out of whack, particularly they're high, which tells you that these types of cancers feed on these hormones. So the higher your hormones, the higher your hormone levels, the higher the chance that you will grow breast cancer. Under colorectal cancer, this has changed. The starting age used to be 50, and that was only 4 years ago. In 2016, the age that you start screening was 50. Now, I think it began last year, it changed to 45. Yeah, I believe in 2019, the ACS changed the recommendation and dropped the age down to 45. That means, does their data show that colorectal cancer is now occurring sooner or earlier?
Yes.
Yeah, that would be the most logical explanation, because why would they drop the initial screening stage to 45? Now, another thing that has changed is in 2016, they still had colonoscopies here, meaning it was the paragraph was very short, and then they had 5 or 6 bullets there recommending endoscopies. So they start with flexible sigmoidoscopy, and then they went on to colonoscopy. You don't see that anymore. There's no mention of, well, except here in the last paragraph, last sentence, when it says, if you choose to be screened with a test other than colonoscopy, any abnormal test result should be followed up with a colonoscopy, meaning the initial, unlike before, wherein the initial test was a full colonoscopy or at least a sigmoidoscopy, Now they start the initial testing with a stool-based exam. So you don't even need to see the doctor anymore. They just give you a kit, you poop, give a sample, send it back to the lab, then they test your stool for a DNA, because now they can test the presence of cancer cells in your stool DNA. So no need for preparation, GI prep, because it's such a hassle when you have to go for endoscopy. I had 2 of them already. It's your NPO, you have to drink this GI cocktail, you poop several times, you empty your bowel, and then you get an IV, they sedate you, and you get um, violated, and you signed up for that violation, and you have to recover afterwards, and you can't drive home because you're still sedated. So there's a lot of hassle with related with endoscopy. So now they just start with a stool-based exam. However, if that stool-based test comes back positive, then you have no choice though. You will need a colonoscopy after that. But at least the initial screening is just a stool exam. Please follow the ages, because the questions on this will be select all that apply, beginning with here under breast cancer, followed by colorectal. So I don't know which one you'll get. Finally, cervical cancer. This has also changed. When I first looked at the American Cancer Society website, that was in 2008, the first bullet said all sexually active women will be tested for cervical cancer, meaning they will get a pap smear. So if that sexually active woman is 9 years old, 10 years old, then they get a pap smear. Now they changed it to in fact, actually earlier this year, they still said 21. I believe it was spring. Yeah, because the spring class, when I opened this, it said 21. And then somewhere, I think 2 weeks after, when we were going into the final exam, when they looked at it, it changed to 25, and then they brought it to my attention. Hey, what are we doing? Are we using 21 or 25? Well, this is American Cancer Society. They update these things constantly, right, based on data. So they asked me, so what do we use? In the recording, it was still 21, and then now the latest update on the website, they changed it to 25. So of course we start 25, but basically these are the changes. Around 2008, it said all sexually active women. So regardless of the age of that sexually active woman, whether that be 9 or 10 years old, then they'll get a pap smear. And then it changed to 21, and now we're at 25. Please do not confuse this, especially if you or someone you know had a pap smear before 25. Whatever that reason was, I'm sure it was not, either it wasn't for early detection of cancer, or that particular patient or person had symptoms, meaning they had a reason why they got a pap smear. All I'm saying is this page on the website is referring only to what? What is this website doing? This particular statement?
Cancers.
Okay, cervical cancer screening purposes. So again, some women may have gotten a pap smear for whatever reason, but I'm sure there was a reason why they got a pap smear. Whatever that was, that's a separate story. All I'm saying is this page is for what again?
Cervical cancer.
Cervical cancer screening. And it should start when? At age 25.
Wait, so
And look at the...
doesn't matter anymore?
Say again?
So once the stage 25 doesn't have the sexual activity.
Sorry, and the audio really it's cutting out certain words in your statement.
I think she said when you're 25, if it doesn't matter if you're not sexually active.
Oh, yeah. Okay, yeah. Sorry about that. So, yes, they cut out that statement altogether. So, as far as I can remember, again, in 2008, they said it was about sexual activity. You know, if a woman was sexually active, then they should be tested. Now they cut out that statement at all. Recently, earlier this year, this was 21 with no condition about sexual activity, and then now they change it to 25 again with no condition regarding their sexual activity. So yes, no more requirement of being sexually active. So if you're age 25 now, you should start cervical cancer screening. And then between 25 and 65, now we'll start testing you for HPV. Unless, well, even if you've had a HPV vaccine as a teenager, you will still be, this is still the recommendation every 5 years. And then if a primary HPV test is not available, a co-test will be done every 5 years or a pap test every 3 years. And here's a bolded statement. The most important thing to remember is to get screened regularly, no matter which test you get, whether it's the HPV co-test or the pap smear. Look at this, same pattern as with in breast. Look at women now over 65. If they've had regular cervical cancer testing in the past 10 years with normal results, then no, they shouldn't be tested anymore after 65. Why is that? Probably the cervical cancer doesn't like old people anymore. That would be my conclusion. You're too old. I don't want you. I'll go to younger people. Right? Okay, what about people who've had the unfortunate experience of getting their uterus removed, okay, for some other reason, for instance? Okay, look at the statement fully. People whose cervix has been removed by surgery for reasons not related to cervical cancer should not be tested. However, if that cervical, which is technically uterine, if that uterine removal, that hysterectomy was related to cancer, do they still get tested? Yes. Of course, there's no more cervix to test, then they'll still do a DNA test or something. Okay, because to just to check that the cancer never returned. And here, as I already mentioned, so people who have been vaccinated against HPV should still follow screening recommendations. So same thing.
With that DNA testing, what do they swab?
Just the pelvic area, because they can remove partials. Let's say they can remove only your tubes, for instance, or only your ovaries, or only part of the cervix, for instance, okay, in some cases. And that's it. I'm not testing the endometrial, although lung cancer is the top incidence and the #1 killer, actually #2 incidence and #1 killer. There's really only one test, which is a CAT scan. That's it. There's really no pap smear or anything. All it says is if you're a smoker, get scanned. That's it. There's really nothing to memorize for lung cancer screening. All right, let's go back to your textbook. So these are all secondary. Why is it secondary again? Why not primary? What's the main difference between primary and secondary?
You got the first one.
Secondary, you already have the.
Okay, and what, yeah, you already have the risk. And what is that risk again?
Carcinogens, AIDS.
No, as far as secondary prevention. So we looked at the, yeah, if you look at here, cancer.org, what common thing do you see? Age. So you got old. You reached a certain age, you hit 45, or in this case for breast, you hit 40. That is your risk factor right there. Doesn't have to be that you have genetics, for instance, that you have a hereditary condition or a history, for instance. Doesn't matter. The fact that you got old, you hit 40, you hit 45, that is your risk factor for cancer. So that falls now under secondary prevention. All other cases fall under primary prevention. As far as tertiary goes, so disregard this one, okay? Table 13.4, because look at the, well, the mammogram breast cancer is correct, but the cervical, see, cervical still says 21 here. And we looked at americancancer.org, American Cancer Society, they changed it to 25. So this is not, look at this one. Obviously, this is old already, probably 2016, because the age here for colon cancer screening is still 50. Now it's 45, right? So disregard, that's why I'm saying disregard table 13.4. Plus, look at colon cancer here. The recommendation is still saying sigmoidoscopy. And then the current guideline on American Cancer Society is what? Do we have to have an initial endoscopy? No, stool, right? Stool-based exam. So disregard this one. Just stick with what's written in the cancer.org website. That's where I'll take my exam question from. No questions around here. Here's tertiary prevention. So tertiary is now after you've been treated for cancer. So let's say you had the unfortunate experience, despite primary and secondary prevention, you developed cancer and now you survived. Okay, you've been treated with cancer. Tertiary prevention is now focused on reducing morbidity and mortality. These are now complications arising from either cancer or the cancer treatment, which can include oncologic emergencies. So tertiary, you can say this will cover rehab as well. Because let's say you had breast removal, you had mastectomy, you may experience lymphedema resulting from the breast removal. So now if you receive treatment for lymphedema, that is now falling under tertiary prevention. Or let's say you undergo cosmetic surgeries to reconstruct your breast, create new nipples, for instance, then that's under tertiary prevention. Any question on? Okay.
You're saying this, the reconstructive surgery is the.
Yeah, that's all part of tertiary prevention. As far as it's not simply, as long as it's not simply cosmetic. Say again?
Like, you would say the reason for someone to get that, like, they would need to have, like body dysmorphia.
Yeah, something like that. Okay. Diagnosing cancer, as far as diagnostic tests go, we will only test biopsy, because although we have what's called tumor markers. Okay, let me give you an example of a tumor marker. Even the CAT scan, okay, so let's say the test they mentioned here, radiological test, ultrasound, invasive techniques, PET scan, CAT scan, MRI, none of them diagnose cancer. They will help you find it though. However, a diagnosis is only made using a biopsy. Even if you see a really large tumor, you can't say, oh, that's cancer. No, you need to take a tissue sample of that mass and then look at it in the microscope and see and identify that it is. However, do you need CAT scans, MRI, or any other tests? Of course you do. However, do they make a diagnosis based on that scan? No. It requires a biopsy. The statement right here says confirmation of malignant tissue requires a biopsy. Right, is that clear? Now, other tests aid in the diagnosis, as well as they also help you evaluate response to treatment. Again, only a biopsy confirms the presence of cancer. All these other tumor markers, for instance, PSA is mentioned here. This is called prostate-specific antigen. You still need a biopsy though, in order to confirm that this enlargement of your prostate is cancer, right? So here, as defined here, as PSA is a test used to validate the presence of prostate cancer. But however, it doesn't say that it will confirm a diagnosis. Again, the what will confirm the diagnosis is really a biopsy. But we can't go doing biopsies, right, left and right. We have to start with the blood test. So we draw PSA. Let's say you have a male patient who's 40 and up over, so now they're at risk for prostate cancer. The doctor typically orders a PSA test. Other tests are, let's say, CEA. Let me show you CEA. Okay. So this is a list of your tumor markers. You have CEA, AFP, a CA125. There are a lot. So let's just look at the oncofetal antigens, for instance. Although it says here that CEA is associated with colon cancer, stomach cancer, lung cancer, pancreatic, and breast cancer, because of the variety of cancers that it's found in, does it help you? I mean, does it tell you what type of cancer you have? No, because we don't know, well, what is this? Are we dealing with colon, stomach, lung, pancreas, or breast cancer? Are you following? Do you know what I'm saying?
Yeah.
Meaning is CEA specific to a type of cancer? No. So even if we draw a blood test, let's say you come in with anemia, thrombocytopenia, neutropenia, right, for no reason, and then the doctor runs a test. Okay, let's check you for HIV, let's check you for cancer. So he'll draw all these blood tests. Let's say CEA comes back high, positive. Can the doctor make a diagnosis based on a high CEA? No way. What the hell are we looking at here? Is it colon, stomach? No. However, it helps. Does it help the doctor get an idea that it could be cancer, sir? Yes. But can we make a diagnosis based on CEA? No. Like we said, it has to be a biopsy, right? So the next step would be you come in with these symptoms. You're losing weight. You look pale. You're in pain. So you look sick. And the doctor does these tests, draws CEA, AFP, or CA125, and then whichever one comes back positive, again, we cannot make a diagnosis based simply on these tumor markers, meaning it helps you it aids in the diagnosis, but we cannot make a diagnosis based on these blood tests. So what we'll do is, if you're positive, then the doctor will examine you and then send you for a CAT scan or a PET scan to find the tumor. Once we find one, then he'll make a biopsy, take a biopsy, and then make a diagnosis based on that. So that's one use of tumor markers, is to aid in the diagnosis of cancer. Another use, which is a better, really a much better use of these tumor markers, is to aid in to evaluate response to treatment, because these oncofetal antigens are produced by the cancer cells. If you are killing the cancer cells, will the levels of these oncofetal antigens remain high if the cancer cells are dying? Will they remain high? Are you still with me?
Can you repeat that?
Okay, so you came in with signs and symptoms of cancer, right? You have anemia, you look sick, you're in pain. Doctor runs some tests, draws a few of these oncofetal antigens. They come back positive. So he sends you for a CAT scan, finds a tumor, takes a biopsy of the tumor, confirms the diagnosis that yes, you have colon cancer. And now you undergo chemo, radiation, surgery, whatever. As we're monitoring your response to treatment, if the cancer is responding to the treatment, it's being killed by chemo and radiation, what happens to the level of these tumor markers, since they are produced by the cancer cells themselves?
They go down.
They go down.
All right, so these oncofetal antigens, these tumor markers, help you evaluate response to treatment?
Yes.
Yes, so that's another use of oncofetal or tumor markers. Are we clear?
Yeah.
So they serve two purposes. One is to aid in the diagnosis, and then finally they help you monitor response to treatment. So what happens, what will be your conclusion if these things remain high after chemotherapy and radiation? All right, that means
But
the
the cancer
treatment
cells
is not, right, exactly. Treatment is not working. All right, let's take a short break, come back at 2:30.